So today's topic is related to nutrition, and we'll be discussing about enteral and parenteral nutrition. Am I audible? Hello,
Yes,
am I
yes.
am I
Yes,
audible?
sir.
Okay. So today's speaker we are having Dr. Jayprakash, who is associate professor in Department of Critical Care and Critical Care Medicine. He is having uh, a number of awards and achievements, and he is editorial member of the editorial boards, reviewers. So, without having much time, so we will be starting on nutrition because nutrition is a very important topic and very important for the patients. We are taking care of the ICU patients. So, over to you, Dr. Jayprakash.
Okay. Thank you so much, sir. So without delaying, I would like to start the allotted topic. Now I'm sharing the screen. So nutrition is very important topic, especially for the nursing student. Once you will go through that, you will feel that what is your vital role. And besides giving medications, besides taking care of patients, one important thing is nutrition, because when a patient land up in the ICU, you will feel that the neglected part is nutrition. So at least we must be aware about that what is nutrition, what is enteral and parenteral nutrition, and why it is important, because nutrition is vital in critically ill patient. And if you look at the why, because it prevents the catabolism, it promotes the healing. So there are two sources. First is your enteral nutrition, which is via GI tract. Later on I will tell you by how you can give, whether it is through the Ryle's tube or whether it is through the jejunostomy, by jejunostomy. One by one we will deal that. And now parenteral nutrition. What does it mean? That the nutrition given by the IV route, whether it is through the central line like IJV, subclavian vein or PICC, any route. So parenteral nutrition. So nursing plays a key role in the safe administration and monitoring also, because the monitoring is also important. If you look at I'm audible.
Yes, yes, yes.
So if you look at the nutritional support, what does it mean? Because it maintains the energy balance and nitrogen equilibrium to preserve the lean body mass, to support the immune system, and also to promote the wound healing and recovery. So now I am coming to the first thing, is the definition. What is nutritional support? So it is the provision of nutrients to patients who cannot meet their nutritional requirement by eating a standard diets. That's why I said that if you don't eat according to your goals, then don't expect to reach them, because the important aspect is that how the patient will recover. So nutrition having the vital role. Now one by one we'll deal that one. So the basis of nutritional support is that, suppose the patient is in a stress or acute illness or surgery or trauma. What is the meaning of the SIRS? Systemic inflammatory response syndrome. Why? Because it is major changes in the metabolic milieu of the body. Why? So suppose that if the patient is having altered substance synthesis rate, changes in the substrate utilization, inflammatory mediators. So all these are the basis of the nutritional support, that it will fight with the body, that not body fight with the ill body. So consequences, if you will look at the inadequate nutrition, what will happen? There will be the loss of the lean body mass, wound healing will be delayed, there will be impaired immune response, what I told earlier, and yes, patient will land up in the multi-organ dysfunction. So now please unmute all the participants. Now I am giving one question, that which one of the following scoring system are not useful for the management of a patient? Nutric score, ICTH score, NRS score, MUST score. I already have shown the answer. So basically Nutric score is also based on the nutrition, NRS score, MUST score all. But ISTH score, if you will see that, what is the full form? Can anyone tell me? Suppose that if a patient is in DIC, disseminated intravascular coagulum, then ICTH score is important there. So what is the full form? International Society on Thrombosis and Hemostasis score. So yes, the answer will be ISTH score. Okay. Now, how you will assess the nutritional status? That means how you will achieve your goal by assessment, that whether my patient is nutritionally adequate or not, whether what we give feeding is adequate or not, what is the calorie requirement of this patient, you have to assess. So one by one we will see that how you will do by looking the sign and symptoms, like that look at the whether muscles and fat wasting is there in patient or not. Patient is have will complain of the weakness. Is there any peripheral edema? Look at the tongue, and you have to see that whether glossitis is there or not. One by one, patient is having many skin changes, all these muscles pain, sometimes heart failure, cardiomyopathy. Also, you will get that. So by looking the sign and symptom, or whether patient is potentially depleted nutrition or not, how you will assess that? By looking the seeing the calories, protein, what is the requirement of the fat, body mass, all these things you have to assess, and then we can proceed with that the nutritional requirement. So subjective global assessment, there are three criteria: A, B, and C. A, well nourished; B, moderately malnourished; C, severely malnourished. So if you will see that whether the patient is having in the previous 6 months body weight loss is less than 5%, so it will categorize into category A. Okay. Again, similarly, loss 5 to 10%, it will be in category B. Loss more than 10%, then severely malnourished. You have to assess the dietary intake, whether patient is anorexic or not, patient feeding habit is good or adequate is there not. You have to see the GI symptoms. Fat, you have to see that by looking the body, abdominal gut, all things you have to one by one. This is the subjective global assessment. Now there is a must tool, but I asked earlier that question, so I told saw that one must tool. So how you will? There are three steps: step 1, step 2, and step 3. That is based on the BMI. So if there is more than 20 kg per meter square BMI, that means patient is obese. So the score will be 1. 18.5 to 20, score will be 1. More than 20, score 0. 18.5 to 21. So these things you have to remember, that whether patient is having weight loss in past 3 to 6 months, they are not. And final, you have to then assess the overall risk of malnutrition, and then you have to add the scores together to calculate the overall risk of malnutrition. And you have to ensure the appropriate food and drink choice, repeat screening every 3 to 6 months. These are the criteria where we have to assess. These all are the assessment tool. Again, if must one care pathway, follow that. Then there is guideline I will discuss later on. I'm not going in detail in that one because I have to complete early. Now, Nutric score. So, Nutric score having how many variables? Six variables. Age, Apache 2 score, SOFA score, how many number of comorbidity. So you have to look at that. When patient admitted, so day from hospital to ICU admission, you have to see that. And IL-6, interleukin 6. If you will see that the interleukin 6, if you will remove, then it will be the modified Nutric score. So 6 variables, you must remember that the Nutric score, which is basically designed to quantify the risk of critically ill patient, that patient develop severe events, and it may be modified by the aggressive nutrition therapy. So if you will see that the scoring system, whether 6 to 10 high score and 0 to 5 low score, what does it mean? So high score, that means 6 to 10 is associated with the worst clinical outcome. So mortality, morbidity, and patient may land up in the on the ventilator. So uh, by seeing this score, you can prognosticate also the patient. You have to manage accordingly, aggressively you have to manage that. If low score though, then this kind of patient having the low malnutrition risk. Similarly, what I told, if you are not including IL-6, then it will be modified Nutric score. I am not going in that one. So NRS score, what does it mean? This is, although this is the older criteria, but it was very simple. So this is, there are three things: initial screening, how you will go that, then final screening, then final screening. Sorry, two. So look at the severity. Okay. So in initial screening, you have to see the BMI, whether it is less than 20.5 or not. You have to assess the body weight during the last 3 months, and the patient whether having the reduced dietary intake. So simple way is that, why I am saying that it is very simple, because you have to tick out only yes or no. If all question no to all, then re-screen at weekly interval. If yes, then directly you may proceed to the final screening. Okay. Similarly, in the final screening, so it is categorized into the whether nutritional status is impaired or not. If nutritional status is adequate, so the it will means the normal nutrition status. If mild, moderate, severe, that is designed on based on the scoring system: score 0, score 1, score 2, and score 3. So all these are categorized in the based on the body weight loss. More than 5% in 3 months, more than 5% in 2 months, or more than 5% in the 1 month. This is very easy to remember, and you have to look at that. The food intake should be the 0 to 25%, that is the normal required in the preceding week, that means coming week. Again, in the final screening, same you have to see that whether patient is having any severe disease or not. Maybe the possibility the patient is having the chronic illness, like suppose that trauma patient, if you are seeing that hip fracture, if patient is coming from the OT, that means the maybe having the major abdominal surgery, patient is a neurological problem, CVA, all these things you have to one by one assess that. What is the impact of all these one? So how much calorie you have to give to the patient, what the dietitian is providing, you have to one by. So this basic structure for the nursing student, they should keep in mind that at least you should know that this, whether this patient we are giving adequate nutrition or not, how we have to care the nutrition, by which route we have to, although these are prescribing by the doctors, But yes, you should know that, suppose that in certain situation, you should know that when we have to give the enteral feeding, when we have to give the parenteral feeding. So if you will see the Spain guidelines, Spain guidelines now it came 2019, that recent one. So if first that in 2000, what it is saying that whether there is impaired nutritional status is there or not, they looked on. I made all this slide in very simple form so that the nursing student can easily understand. So what exactly we have to see, that BMI, weight loss over time, how much calorie patient is taking, and whether severity of disease. If you will see that just before I said that, though, by seeing the score 0, 1, 2 and 3, and sometime if you will see that the patient geriatric patient that is over 70 years, automatically you have to add 1 point. So if the total score is 3 or more, then yes, nutritional support is indicating in that patient. So suppose that if you are assessing the nutritional status and you felt that yes, this patient is having adequate nutritional status, then what you have to, patient is conscious oriented and talking nicely. So oral diet, reassess nutrition strategy, and if the patient, you meanwhile you have to maintain the hydration also. Look at the nutritional status. If it is not adequate, then select an appropriate feeding route, whether it will be enteral or parenteral, whether GI tract, that means gastrointestinal tract, is functioning well or not. If yes, then appetite, you have to see that when patient is your demanding food, if not on ventilator, patient is conscious, suppose that patient is in ward, you are taking care. So at that time you have to make a chart, patient demanding food, how much calories your dietitian provided, one by one you have to look that. And if GI tract is not well, then for suppose that short term only short term support anticipated, you have to see not severely malnourished. So what your doctor prescribed, accordingly you have to proceed with that one. Now the route of nutrition support is enteral nutrition and parenteral nutrition. I already told that enteral nutrition, that means through the GI tract. Okay, so in enteral nutrition, the delivery of nutrition is directly into the stomach, or sometimes we are bypassing the stomach. So either in a stomach or in a small intestine. So what is the benefit of that one? So if you will early enteral nutrition is, most of the trial is saying that the enteral nutrition is always better. Why? Because the functioning of the GI tract is good for that one. So if you will see the enteral nutrition, many times you are seeing in your ICU that patient is on ventilator and patient is having the rice tube, and through the rice tube we are giving the nutrition food, liquid food. So that is your enteral nutrition. So what is the indication of the enteral nutrition? First thing, remember that the GI tract should be functioning. Second, patient is could be either of a stroke, sepsis, and patient may be on ventilator. So at what is the advantage? So it preserves the gut mucosa, and if you will see the many literatures, it is saying that it reduces the infection risk, and most important thing is the cost effectiveness, because parenteral nutrition is quite costly. And what does it mean by the parenteral nutrition? That the administration of nutrition via IV route when GI tract is not functioning. Sometimes in abdominal surgery, this is the basic things example, so you can understand that one. So what are the indications of the parenteral nutrition? Bowel obstruction by uh, hearing through the stethoscope, you are not getting the bowel sound. So that means patient bowel obstruction is there. So severe pancreatitis, you can also go for the parenteral nutrition, short bowel syndrome. And now the what is the disadvantage in that one? So because we are giving through the central line, peripheral line, all these things, so the chances of the infection, that is catheter related infection, is quite common. So by giving so much of fluid, overfeeding, the chances of the hyperglycemia, electrolyte imbalance is quite common. And what I said earlier, yes, costly. So the basic important thing for the nursing care in enteral nutrition is the pre-feed assessment. See the bowel sound, hear the bowel sound, confirm whether tube placement of rice tube is there on proper place, is not, is there, and head is elevated 30 to 45 degree, proper position it should be. And then you have to again monitor whether patient is tolerating or not. Patient, if not tolerating, patient may vomit, abdominal distension will be there, patient may be complain of the diarrhea. And important thing for the medical legal purpose, for the your because you are going to help to your doctors also. So intake, how much patient you have provided the nutrition to the patient, you must mention in the file. Similarly, if you will see the parenteral nutrition in case of first, uh, important thing you must be remember that aseptic technique. So because you are giving through the IV line. So must be aseptic technique. Look at the complication. Daily assessment is important. As I said, many times you will see that there is rebound hypoglycemia. Then taper parenteral nutrition gradually. Labeling is important, and when date of infusion sets, so you have to mention in your file. Now, so these are the advantage. What I said, that enteral nutrition is more physiological, lesser cardiac work, safer and more efficient and better tolerated by the patient, and yes, more economical. Now enteral nutrition access. What I said, that how you are giving that, whether by sip feeding, that means by a spoon you are liquid that you are giving, that sip of, what exactly we are saying, that sip of food we are giving. Patient should be conscious, cough reflex, gag reflex, all. Otherwise, patient will aspirate. Nasogastric tube or gastroduodenal or nasojejunal tube, we are sometime bypassing. Suppose that if you are any complication in a stomach, so sometimes we are bypassing the stomach. So nasojejunal tube, that is called nasojejunal tube. Gastrostomy, by gastrostomy we are giving that. Suppose that patient is so much traumatic injury, so we are not putting the rice tube. In that case, we are directly going through the gastrostomy. Similarly, jejunostomy and pig also. So look this by the figure, first figure, where you are seeing the nursing staff is giving through the rice tube. Okay. Now this is your feeding jejunostomy, directly they attach. Okay. Now, what is the contraindication of the enteral nutrition? When you have to prohibit for the enteral nutrition, whether patient is, look at the whether patient is hemodynamic unstable or not. So always go for the, when the patient is hemodynamic stable, what I said, intestinal obstruction, any GI bleed or paralytic ileus is there, because food will not move on, there is intermingling with the blood. Okay. So chances of the intractable vomiting, suppose in case of intestinal obstruction you are continuously giving that, so patient may in aspirate. How a high output proximal fistula, inability to gain access and anticipating complication. So these are the aspects where we have to provide for the enteral nutrition. Now How you will initiate and advance the tube feeding if the patient cannot tolerate an increased delivery rate, feeding rate slowed until the person adapts. Similarly, slower delivery rates better tolerated, such as in critically ill patient. Concentrated formula use, I will show you that formula how you have to give that, and patient who have undergone or an extended period of bowel rest. Now, so enteral nutrition transition. First thing is the transition to a stable food. Then transition step depends on the patient medical condition, which kind of food, type of feeding you patient is receiving, and tube feeding should be discontinued when patient is allowing the oral intake. Okay, so at least it should be 2 or 3 times. So what are the complications of the enteral nutrition? First, remember that the tube related may, if you are be possible that if you are putting the rice tube. So what exactly you people are doing that by 50 ml syringe, taking 50 ml syringe, you are showing the whether sound you are hearing on after keeping the stethoscope, whether tube is on proper place or not. So tube related complication is the malposition, displacement, maybe block or break or leakage. And in case of gastrointestinal, if you will see that chances of the aspiration, paralytic ileus, like that. Metabolic, yes, what I said, electrolyte disorder, vitamin and mineral deficiency, and maybe the possibility of the drug interaction. If you are not maintaining the hygiene, then chances of the infection is also. So what Spain guidelines is recommending on enteral nutrition, that is very important. So always go for the continuous rather than the bolus enteral nutrition. Why? Because if you will give bolus, then the chances of the aspiration or vomiting is quite more. That is based on the many studies, and the grade of recommendation is the strong. That means we have to follow that, because a strong recommendation. If oral intake is not possible, so go for the early enteral nutrition, and it should be within 48 hours, especially if patient is in ICU. Okay, and if in case of the gastric feeding intolerance, then intravenous metoclopramide, what we have perinorm we are giving now. So that is your metoclopramide, or a combination of metoclopramide and erythromycin. Erythromycin we are giving. Why? Because it acts on the motilin receptor, so the bowel movement will be there. So it acts as the prokinetic therapy. Prokinetic means it will expel from upper GI to lower GI. I am just trying to explain in your words so that nursing student can easily understand. So these are the recommendation. If suppose that hypocaloric nutrition and not exceeding 70% of energy expenditure, then should be administered in the early phase of acute illness. Okay. Now, how you have to calculate the nutritional requirement? There are two methods. What gold standard method is the indirect calorimetry and predictive equation. Although we are just taking a rough data, not accurate, but yes, it is also helpful. So Harris Benedict equation, what does it mean? For men, the basal energy expenditure is 66.5. In case of female, it will be 65.5. And then 13.7. You have to remember this formula. I am not going in detail, but overall, this is the most practical method of the calculation. Okay. So if you will see the resting energy expenditure, so basal energy expenditure into 1.2, then based on this formula into basal energy expenditure plus thermal effect of the food intake. So only you remember these two formula, but here it is mentioned. Okay. Now, so the total energy requirement, if you will see that the energy requirement of patient depends on the activity status. Most of the patient we are seeing in ICU is immobile. Patient is not always on bed, and the amount of stress is also quite high. So, based on the stress factor, whether mild, moderate, severe, you have to see that. So, total energy requirement is resting energy expenditure into a stress factor. Okay, this is the rough calculation, and the proteins are not included in this calorie calculation. So what is the protein requirement? As per the Spain recommendation, at least 1.3 gram per day of protein is requiring, so that the patient who are critically ill should achieve their target. These you these all data came from the study. We are also following that. But once you are working in your ICU, your dietitian will help you. They will uh, prescribe all that, how much calorie is required for every particular patient. Okay. So protein dose should be adjusted based on the patient's specific disease, route of administration, and the clinical progress. Okay. In case of the patient is chronic illness, then high protein targets are recommended after initial combined with the exercise. Now coming again to the question, based on what I taught earlier, that in which of the following condition would you prefer parenteral nutrition over enteral nutrition? Anyone? How many participants? Anyone?
12 participants are there.
Okay, so which condition you have to prefer parenteral nutrition over enteral nutrition? Then perforation peritonitis. Why? Because enteral nutrition is through the GI tract. Already patient is having perforation with peritonitis. Okay. So in that case, you prefer parenteral nutrition. That means through the IV route. Now, indication parenteral nutrition, I already told that gut not functioning, severe pancreatitis, patient might having the paralytic ileus, enterocutaneous fistula, and then contraindication of enteral nutrition. Suppose that patient is traumatic patient, massive GI bleeding, patient is on NORAD support, vasopressin, adrenaline, all you are seeing that. In that cases, better to go for the parenteral nutrition. And if still by enteral nutrition, patient is having inadequate caloric achievement, then you have to, how you will go assess? By already you told, by the assessment tool, by the scoring system, you have to whether patient is having adequate caloric achievement is there or not. Okay. So total parenteral nutrition, entire caloric requirement of the patients are provided, partial supplement to enteral nutrition feeding. What does it mean? Means we are giving through the rice tube or feeding jejunostomy, but still simultaneously we are providing some with parenteral nutrition. So that is called partial supplemental to the enteral feeding. Look at this central line, whether it is a subclavian, internal jugular, or femoral vein. So these are the line where we are giving that parenteral nutrition, PICC also, and so these are through the central line, central axis, okay, and these are through the peripheral axis. That the peripheral parenteral nutrition through the PICC or through the we are putting the simple in the peripheral venous line. Okay. So the components of TPN, if you will see that, I said that this is the costly. I am working in the government organization. So we are generally avoiding the parenteral nutrition. Why? Because it is costly. So if you will see that different kinds of, you have to see that the what is the caloric requirement, what is the energy. So 25 to 30 kilocalorie per kg per day on non-protein calories. Okay, dextrose also we are giving to achieve the parenteral nutrition order to 60 to 70% of the non-amino acid calories as dextrose. Lipid we are giving that. Protein amino acid we are providing. Yes, water, that means NSRL, we are giving that. Sodium, potassium, all these are through the components of the total parenteral nutrition. You all are must be aware about all because you are regularly prescribing that. Okay. I'm not going in detail. So this photograph you have to at least see that. See above photograph, lipid is there, fat. So pre-mix three or in or binary. There are many formulations which are coming nowadays. I'm not going in that one. So if you are starting the nutrition, so checklist, there must be checklist in your ICU. So clinical assessment is as important. What I earlier told, the nutritional stat, whether it is severe or deficiencies, you have to assess the weight loss in at least 3 months if chronic patient, and blood sugar level, serum electrolyte, RFT, LFT, serum triglyceride, lipid profile, and yes, in case when a patient is on mechanical ventilator, we are seeing by the blood ABG. Okay. So how to start the first, start in a dedicated line. TPN, how you will start? Always through infusion pump. Can start with the 50% of the caloric requirement in a day 1 and escalate to full estimated caloric requirement by day 3. These all are advised by your dietitian. Infusion should not be more than 24 hours, and if you are not using, better to discard that one. So when to import initiate, so the timing is very important in the parenteral nutrition. Why? Because suppose that there are many studies whether early parenteral nutrition versus delayed parenteral nutrition. I'm not going in that one. So timing is very important. So right place, maybe the possibility of right place, wrong time, on wrong place, right time. So timing is very important in that case. If you will go through the literature, what the earlier study is saying, that the timing of initiation of the parenteral nutrition in critically ill adults in whom caloric targets cannot be met by enteral nutrition alone, then in that case, early initiation group. What does it mean by early initiation? That means you are after starting within 48 hours of ICU admission, and in late initiation group, not started before 8 days of ICU admission. So they did a study on these two groups, and what they achieved, that in the late initiation group had increased likelihood of earlier discharge from ICU and hospital. Chances of the infection was fewer. Patients were on less mechanical ventilation days, less RRT days, and cost effective, you will see that it was also less. So total parenteral nutrition in case of critically ill patient, what they concluded that total parenteral nutrition does not influence mortality in surgical and critically ill patient. It reduces complication rate, especially if patients were malnourished. Similarly, if they studied whether we should go for the enteral nutrition or whether we should go for the parenteral nutrition, there is criteria indication which I already dealt that one. So if you will see, suppose that when you have the patient is conscious oriented, all these, so if you will see that mortality is higher and the risk of infection tends to be higher with in case of parenteral nutrition, especially in malnutrition patient. So what is important during for the monitoring feeding regimen? If you are starting TPN, then daily, weekly, and fortnightly. So daily you have to see the body weight, what is the temperature, CBC, RBS, blood urea nitrogen electrolytes, all you have to monitor properly if you are starting the total parenteral nutrition. In case if you are monitoring required then for weekly plasma protein, LFT, acid base status, and essential elements like calcium, magnesium, zinc, phosphate, all these things you have to monitor. Okay, so undernutrition, the chances of the refeeding syndrome, chronic deficiency, and if you giving so much of TPN, the chances of hyperglycemia, hypertriglyceridemia is quite common in this overfeeding. Chances of the sepsis is also common because you are giving through the line. So in that cases, catheter related infection is quite common. Hai. So advantage of you will see that enteral versus parenteral nutrition. Yes, what I said, gut integrity will be preserved in case you are giving food through the enteral nutrition. Decrease bacterial translocation, preserve immunological function of gut, reduces cost, fewer infection complication, and cost effective also. Now coming to this question, a 65-year-old alcoholic male was started on TPN post-thoracic oesophagoectomy for an esophageal malignancy. Post-op day 3, he developed drowsiness, respiratory distress, and cardiac arrhythmia, necessitating intubation and mechanical ventilation. What is the most probable diagnosis? Patient was on previously started on TPN. So now correlate because today I am taking lecture on the enteral versus TPN. Okay. Anyone? You people are not communicating.
Sanjita has answered A.
No. Anyone? Okay. So this is refeeding syndrome. Just before I told you, na, the patient developed respiratory distress, cardiac dysarrhythmia after TPN. So it should be, you can correlate with that one anyway. So what is refeeding syndrome? So refeeding syndrome is occurrence of severe fluid and electrolyte imbalance in severely malnourished patient while starting early nutrition or total parenteral nutrition. So this is quite common in TPN. Okay, so the causes is hypomagnesemia, hypocalcemia, hypophosphatemia. So in due to that reason, patient was having myocardial dysfunction, respiratory changes, and altered liver function also. Okay, so these are commonly seen when the patient is having the chronic starvation, severe anorexia, patient is not tolerating food habit, or patient is having anorexia, not eating, and alcoholic patient also. So gradual feeding and correction of all these metabolites are important in that case. Look at the electrolyte and vitamins and correct it one by one. So home parenteral nutrition, you heard this word. What is that? It is a very popular in the western countries and it is indicated who require nutrition for the long term, because you can't keep patient for many days in ICU. Once the patient is stable, hemodynamically stable, patient is talking conscious, but yes, still require nutrition, adequate nutrition. So especially in case of Crohn's disease, mesenteric infarction, we are giving the home parenteral nutrition. So patient uses the TPN fluid as advised at home. And in developing celastic catheter, what does it mean? So it will last long. Hai, is designed for the long term use. Patients should attend the TPN clinic weekly, follow up or any complications. So these are the basic fundamental things for the home parenteral nutrition. Thank you. Hello.
Hello.
Ah.
So, thank you, Dr. Jayprakash. Are there any question from candidates? They want to ask any question? I think there is no question. So I just want to summarize and want to give some practical tips. So one is that we doctors and nutritionists plan everything like in terms of the calorie nutrition plan. But what is most important is whether my patient is getting it or not. That is
Yes.
the most important part, because we write everything, and if my patient is not getting, so in between doctor's plan and patient getting, there are two stakeholders. One is the nutritionist and second is the nurse. So nurse has to be very vigilant. Means if we have to give two scoops and then that box should supposed to be finished by some time, so it should be checked by the nutritionist as well as by the nurse also. So that part is very important. And because I have there are certain statement or questions, so you can this is for the candidates, you can answer it as yes or no. So based on the this. So starvation or undernutrition is okay for the patients in ICU. So what is your answer? This question is for the candidates. You can answer. You can be the answer is simple yes or no.
I summarize in very simple words because nursing vigilance basically ensures safe, effective, and complication free nutrition therapy. And hello? So no one is replying that.
They are not replying. Anyway, so another statement is whether the enteral nutrition is contraindicated in patients who are on vasopressors. So whatever I'm asking, the answer for the most of the statements is no. I mean, this is so you should not discontinue nutrition in any patient who is on vasopressors, maybe 2 meals or 3 meals or whatever. If it is multiple high, even then you should try to give trickle feed. Small feed, tropic feed should be. That is, as Dr. Jayprakash has already explained, that it will protect the mucosa, enteral mucosa, and gut translocation, and sepsis will be prevented. Another one is early enteral nutrition is not important in patients who are mechanically ventilated. So because these are the practical questions which comes in everybody's mind, and of course the nurses and other clinicians also. So we should be knowing that this is again answer is no. We should it start it. So idea is ki you should always ask a questions to yourself, why I'm not able to feed my patient, whether enteral or parenteral. So you should be able to feed your patient as early as possible, preferably within 24 hours. And once your patient is stabilized, even your patient is stabilized on vasopressors, start as a trickle feed. So
So
I
that means
think
that right route, right care, and right rate, that is going to ensure your calorie counts. So you must be remember this: right route, right rate, and right care, because care is also important.
and aseptic precautions most important while you are dealing with the TPN or PPN. So you should wash your hands, use all aseptic precautions, dedicated port, clean the port whenever you are starting. So these are the few things which are important. Another is a question comes when the patient is pancreatitis. So should we start enteral nutrition? Yes, it is should be started. Right. So I think candidates are not interactive. Please answer or participate. That is a good idea. You should participate in this. Your any of your questions are welcome. Please feel free to ask your questions. If you have any doubt, anything, please ask your questions. Or if there is no question, then we come to the end of the session. So thank you very much. Thank you, Dr. Jayprakash. It was a very nice session. You have explained it in the very simple words and simple language. which our candidates, nursing candidates can understand. And I'm very sure it will be helpful for them. Personally as a professional and for the exam point of view also, and definitely our patients will be benefited wherever they are working. Thank you very much. Thank you for the participation. Thank you, candidates.